Welcome to my session on obstructive jaundice. Today I'll be talking about the guide to clerking a patient with jaundice, and I'm especially referring to a patient with obstructive jaundice or surgical jaundice as we call it. Before we proceed, a short refresher on the anatomy of the biliary system. This is the liver, these are the intrahepatic ducts, the right and left hepatic ducts is joined to form the extrahepatic ducts, the common bile duct, which enter into the second part of the duodenum. Okay, and what happens? Imagine what happens when there's an obstruction in this part of the duct or anywhere along the duct. Okay, the consequences of duct obstruction. First, there's initial dilatation of the proximal segment, okay, which drains the bile. So as a result, there's dilatation, and because of this, there is stasis. Okay, dilatation leads to stasis of the bile, and this stasis predisposes to secondary bacterial infection, especially gram-negative infection, and that can cause infection of the ducts known as cholangitis. The next possibility is that the bile that drains from the liver to the intestine is blocked, and therefore the bile does not reach the small intestine where digestion takes place. As a result, there can be some degree of malabsorption, especially of the fat-soluble vitamins and substances. This obstruction again leads to a backflow and accumulation of conjugated bilirubin in the liver, which then refluxes into the blood system, and that causes jaundice. Okay, the yellowish discoloration of the skin, mucous membranes, and conjunctiva. Long-term obstruction leads to chronic inflammation and cirrhosis of the liver, and this can even lead to liver failure if it is long-standing. Okay, a short recap of the bilirubin metabolism. What happens to bilirubin? Okay, the bilirubin metabolism takes place in three main phases, or three main three main media. The first is the extravascular field, or the blood, where the RBC is destroyed and that produces unconjugated bilirubin. This unconjugated bilirubin is not water soluble, and it is therefore combined with the albumin to be transported into the liver, which is the second phase, or the second media of reactions. In the liver, within the hepatocytes, a series of chemical reactions take place, whereby the unconjugated bilirubin becomes conjugated with glucuronic acid to form conjugated bilirubin, okay, which is water soluble and easily carried around. This conjugated bilirubin is excreted into the bile ducts, which then subsequently carry from the liver the bile into the small intestine, the second part of the small intestine, where the third part of the third phase of metabolism takes place. That is, the conjugated bilirubin acted on by the bacterial proteases to produce urobilinogen. And the vast proportion of this urobilinogen is converted to feces, stercobilinogen, and excreted in feces. It must be noted, the stercobilinogen is the chemical that gives feces the normal brown color. A small portion of urobilinogen enter into a enterohepatic circulation between the small intestine and the liver, which is the recycling of the urobilinogen. And small amounts of this urobilinogen diffuses into the circulation Then it is carried to the kidney, which then excretes it as urobilinogen in the urine. Okay, these are the three phases or three prehepatic. These are also called the prehepatic, intrahepatic, and posthepatic phases of bilirubin metabolism. Now, let's see what happens when there's a blockage of the bile ducts here, and this red arrow here, there's a blockage of the bile duct. What happens to this bilirubin then? Okay, the conjugated bilirubin is unable to reach the small intestine, and as a result, there's a high concentration of conjugated bilirubin builds up within the liver, and this then refluxes into the circulatory system and is carried by in the blood, and a high level of conjugated bilirubin is obtained in the circulation in the blood. As a result, some of the urobilinogen is carried to all over the body in the circulation and is responsible for the yellowish staining of the tissues, especially mucous membranes, conjunctiva, and the skin, and that causes jaundice. Okay, in jaundice, the serum bilirubin is markedly elevated, the conjugated bilirubin. Some of this urobilinogen, which comes from the high concentrated area of the liver, is also filtered by the kidney, and this conjugated bilirubin excreted in the urine gives the dark color of the urine in patients with obstructive jaundice. So in these patients, this is due to high level of conjugated bilirubin in the urine, which is known as hyperbilirubinuria. So these are the changes that occur in obstructive jaundice: yellow discoloration, dark urine, and pale stools are all explained by the mechanisms which I've described just now. Okay, these are the causes of obstructive jaundice, okay, which is listed as intraluminal, transmural, and extraluminal. Okay, the arrows, the blue arrows, indicate the common causes that we often see in our patients. First among them is the CBD stone. It is an intramural cause, and it is the most common cause of bile duct obstruction. Okay, and then this is also known as cholangitis. Parasites as cause of obstruction is relatively rare these days. And among the transmural causes, the cholangiocarcinoma or the adenocarcinoma arising from the mucosa of the bile ducts is a common cause of obstruction jaundice. Okay, strictures usually due to passage of a stone, gallstone, or due to iatrogenic causes such as post-operative post-cholecystectomy complications or ERCP procedures can also give rise to strictures. Choledochal cyst is a congenital condition, cystic dilatation of the bile duct, and this occurs in children. Among the extraluminal causes, carcinoma head of the pancreas is the most common. Okay, as we know, the bile duct passes through the head of the pancreas, posterior surface of the pancreas, and any mass or tumor in this pancreatic head causes obstruction of the bile ducts and jaundice. Another cause is the periampullary tumor, okay, which is a tumor arising from the ampulla of water. Lymph nodes can also be cause extrinsic compression, secondary lymph nodes, Mirizi syndrome, and accidental ligation of the bile duct during surgery. So the common causes can be divided into benign or malignant. Benign causes are choledocholitis, strictures of the bile ducts, and the malignant conditions classed as a triple carcinoma of obstructive jaundice, namely CA head of pancreas, cholangiocarcinoma, and periampullary carcinoma. The chart on this right here clearly shows the different phases of this jaundice in the patients. Okay, A here, prehepatic is due to hemolysis, hepatic is due to hepatitis, drug cholestasis, and tumors, and another common cause is cirrhosis of the liver. And post-hepatic, which I mentioned, all these causes are all given here. All right, gallstone and the various tumors. Now, what are the symptoms that the patient complain when you get a history from the patient? It's very important for you to get a very good history from the patient on the various symptoms that he has got. The most common symptom is pain, and pain is usually in the right upper abdomen and epigastric region. Okay, and the pain is usually related to food, aggravated by food, and also sometimes may radiate to the back as well as to the right shoulder. Then there's jaundice, yellow discoloration, which I've already mentioned, due to increased levels of conjugated bilirubin in the blood. Dark urine, also high levels of conjugated bilirubin excreted in the urine. The resulting hyperbilirubinuria causes dark colored urine, which the patient usually describes as tea colored. Then there can be pale stools or clay colored stools due to absence of stercobilinogen due to the absence of bile in the intestines. Pallor, sometimes the patient will be pale because of the hemolytic jaundice. Itchiness due to obstructive jaundice. Deposition of bile salts in the skin. Fever, you must get to the more details of the fever, especially chills and rigors, which are commonly seen in patients with obstructive jaundice and cholangitis. Must go into the details of loss of appetite and especially loss of weight. Patients with malignant tumors causing the obstructive jaundice usually have very significant loss of weight. Okay. Now, after the history, you have to do a thorough physical examination to pick up the signs that are usually accompanies in patients with obstructive jaundice. Okay, they are clinically jaundiced, and the place to look for is the eyes, the mucous membrane over the oral mucosa, especially under the tongue, and the skin, especially over the palms. You have to look for scratch marks due to obstructive jaundice, the position of bile salts under the skin, and this usually is seen over the forearms, the chest, and the abdominal wall. You must look out for patients with severe loss of weight. They may be emaciated or cachectic, okay, which are very common in these patients with the triple cancers of the bile duct obstruction. They can be having bruising, especially over the skin and venipuncture sites, due to lack of vitamin K and coagulation disturbances. Hepatomegaly is another common sign, manifestation of obstructive jaundice, especially in the tumors. Splenomegaly may accompany when this increased portal pressure due to liver involvement. Gallbladder may be enlarged, especially when tumor is the cause of obstruction of the bile ducts. In keeping with the Cohesius law, Must carefully palpate the abdomen to look out for abdominal masses, especially in the region of the right hypochondrium and epigastric region, and also where the gallbladder may be palpable, and also in the lower epigastric and right paraumbilical areas where pancreatic tumors may be palpable. You must look out for ascites and other evidence of malignant secondaries. Ascites must be carefully looked for by doing a shifting dullness, and also edema of the legs, okay, pedal edema, pitting edema of the legs, and a careful rectal examination to look out for secondary deposits in the pelvis. And also sometimes you may get some pale stools in the finger, and which may help you to confirm the presence of obstruction. Now, in order to proceed further into the diagnosis, when you take the history and you do the examination, you must always keep the common causes at the back of your mind. So you must have an understanding of the common causes of obstructive jaundice in order to determine the cause in that particular patient of yours. And this is a list of the common causes. The first four are the most common: cholangitis, bile duct strictures, acute pancreatitis, and malignancy. As I told you, the triple malignancy: pancreas, cholangiocarcinoma, and ampulla aorta. The lesser causes are inflammatory or hereditary conditions such as sclerosing cholangitis, congenital conditions like biliary atresia, choledochal cysts, and of course, must not forget medical causes, hepatitis, and hemolytic jaundice. And then you have the important eponyms that must be kept in mind when you examine the patient or clerk the patient. Cuvier law, he states that in a patient with obstructive jaundice, if the gallbladder is palpable, then it's unlikely to be caused by a gallstone obstruction. It is usually caused by malignant diseases, which I mentioned just now. Murphy's sign is the stoppage of respiration in inspiration when pressure is applied over the right hypochondrial region. This is due to the enlarged or inflamed gallbladder. Charcot striate of right hypochondrial pain, fever, and jaundice are indicators of cholangitis, acute cholangitis. And Raynaud's pentad, addition of hypotension and mental disturbances in addition to Charcot striate, which is an early sign of gram-negative septicemia in a patient with obstructive jaundice. So in order to proceed further, to continue with the examination and history taking, it's very important to have a simple classification of the jaundice. Jaundice is when the serum bilirubin exceeds 1.0 mg/cent. The normal range is 0.3 to 1 mg/cent. Anything more than that, the patient develops jaundice. In prehepatic jaundice, as I said, there's overproduction of bilirubin, and this is usually due to excessive hemolysis. In hepatic jaundice, there's impaired hepatic function. Hepatocellular dysfunction is in handling the bilirubin, affects the uptake, metabolism, and excretion of bilirubin. Okay, so in this type of conditions, both conjugated and unconjugated are equally elevated. And post-hepatic obstruction is usually due to obstruction to bile flow, obstructed bile ducts. Intrahepatic cholestasis, as I already mentioned, the causes are also can be classified as obstructive jaundice. But the more important is your extrahepatic obstruction, which is also called the surgical jaundice, where the bile ducts, the common hepatic and the common bile duct, are virtually or physically blocked by the presence of a gallstone within its lumen. Okay, these are the causes of jaundice in general. Okay, the hemolytic jaundice and the hepatocellular jaundice, and here we have the extrahepatic cholestasis or extrahepatic obstruction, which is the topic of discussion today. Gallstones, strictures, and cancers, pancreas cholangiocarcinoma and ampullary carcinoma, are the common causes. It is sometimes useful, in fact most of the time it is useful to classify jaundice as painful and painless. Okay, what is painless? What is painful? Painful jaundice is usually the result of gallstone cholangitis. Okay, that is the most common cause of painful jaundice. Other causes are hepatitis, liver metastasis, secondaries from somewhere elsewhere, and the Budd-Chiari syndrome or obstruction of the post-hepatic veins, as giving rise to congestion of the liver. But the most common is related to gallstone, biliary colic, pancreatitis, cholecystitis, and cholangitis. And the most common presenting feature of bile duct obstruction of the by a stone is inflammation of the bile ducts, called acute ascending cholangitis. This is due to stasis of bile, secondary bacterial infection that causes the severe inflammation of the bile ducts, and that is cholangitis. It is a clinical syndrome characterized by fever, jaundice, and abdominal pain, the right hypochondria, that develops as a result of stasis and infection in the biliary tract. Okay, and its presenting features are the Charcot's triad, fever, abdominal pain, and jaundice, plus Reynolds penta, confusion, and hypotension, which are signs of early septicemia. And it is a very emergency situation where urgent treatment is required with broad spectrum antibiotics and biliary drainage by ERCP. Okay, what is painless jaundice? Painless jaundice is when there is not much pain despite the patient having gross dilatation of the ducts and jaundice. Okay, and the common causes which I mentioned: clear head of pancreas, ampullary carcinoma, cholangiocarcinoma. So painless jaundice is an indication of more sinister causes of the obstruction. Other causes of painless jaundice can be hemolysis, hyperbilirubinemia, hepatic cirrhosis, so chronic cirrhosis, chronic condition, so there's not much pain, and drug-related or autoimmune cholestasis. Okay, classifying into pain and painless, painful and painless obstructive jaundice. Okay, pain is usually gallstone related, cholangitis, acute onset, matter of days to 1 or 2 weeks. Within that short period, most of the time is due to a gallstone in the CBD, which has come from the gallbladder. And this stone gets infected, especially in the lower end of the CBD, resulting in bile duct stasis, distension, and secondary infection to cause cholangitis. And you must very carefully look for this Charcot's triad. A patient with Charcot's triad is a very good indicator for diagnosing cholangitis. Okay, and Raynaud's is a more severe form of cholangitis. The other thing is intermittent and progressive. This jaundice, pain, and fever is usually intermittent and progressive. So acute onset, intermittent, and progressive. Okay, these are the terms that we use to describe. And there is severe pain, tenderness, and guarding in the right upper quadrant of the abdomen. And in these cases, the gallbladder is usually not palpable. Okay. Whereas in painless jaundice, the patient does not complain much of pain, but more of fullness or discomfort in the upper abdomen, especially on the right side. Painless jaundice usually indicates a malignant cause, with the triple CA that we mentioned. It is chronic in onset, goes into a few months, few weeks to few months, and the jaundice is progressive, okay, compared to intermittent in painful situations. There may be a mass lesion in the right hypochondrium, which may be an enlarged gallbladder or liver, and it can also have a mass in the lower epigastric region and right paraumbilical region, a mass in the head of the pancreas. As I said, these patients are usually have marked weight loss, and this must be clearly noticed in the patient. Also, look for metastasis, ascites, edema, which I mentioned, and look for a enlarged liver or gallbladder. Enlarged gallbladder is an indirect indicator that the cause may be malignancy. That is in keeping with the Oasis law. Finally, this is a flow chart to show you how you go about managing this patient. From the history, you should be able to get a history of jaundice, physical examination, and history. You can get a jaundice patient here. Then if their stools are pale and the urine is dark, then most probably is a post-hepatic obstruction. Then you look for pain. If there is pain, then it is most likely colicky, intolerant to fatty food. The pain is localized to the right hypochondrium. Okay, and this is usually suggestive of gallstones. If there is no pain, then think of malignant causes, more sinister causes like weight loss, backache, and non-specific symptoms like loss of appetite. With this, consider highly a malignant cause. Another important parameter to look for is fever. If there is fever, get into the details of the fever. High fever, chills, rigors, all this will suggest some form of secondary infection in a patient with gallstone obstruction. There may be early signs of gram-negative septicemia. So these patients must be treated with urgency and aggressively. If there are no signs of obstruction, then consider the prehepatic and hepatic causes of jaundice and refer to the appropriate specialties for further management. In summary, obstructive jaundice is caused by obstruction of the bile ducts. It's a relatively common condition and may lead to grave consequences if left untreated. Symptoms and signs are quite straightforward and easily elicited if only you understand its pathophysiology of the jaundice. Always, we must remember and keep in mind the common causes then we quiz and examine the patient with obstructive jaundice. For more information on obstructive jaundice, please visit my YouTube channel in this given link. Till I see you again in another session, thank you for joining.